Hello students, welcome to this session. So the INICET May 2025 has recently concluded, and I spoken to a lot of students and got a few mixed reactions as to how the exam went. But looking at the questions overall and also orthopedic questions, felt like an easy to moderate exam where they've not given a lot of twists and turns in the questions. Most of the questions were straightforward with a few ones which had a kick in it. Okay, so let's discuss about the orthopedic recall questions, and the main question is, why is my recall going to be different from the other recalls which are already out there? So I've tried to include all the orthopedic questions. I've seen most recalls missing out on a few questions, so total of 8 orthopedic concepts were asked and I've tried to include all 8 of them. I will also discuss the concept behind the question, not just give you the question and the answer, because that is of no use. You are going to study for your next exams now, mainly the upcoming NEET PG exam, and you need to understand these topics because these are all high yield topics that will again be repeated in your NEET PG or your next INICET exam. So don't just understand the PYQ, understand the PYT, and I will tell you the concept behind each of this. Okay, so coming to the reflection of how orthopedics was in the INICET exam. See, one concept in INICET that will never change is that high yield topics will always get repeated. Questions might change, they might become more detailed, but high yield topics will always repeat. Osteoporosis will always be there, osteomyelitis will always be there, rheumatoid arthritis will always be there, TB spine will always be there. And one thing that I've observed is a new pattern of questions coming up is the concept of proximal femur fractures. In 4 INICET exams consecutively, they've asked about proximal femur fractures. So looking at that, the topics were all very predictable, except for I think scaphoid fracture, which you can say is not very commonly asked, but again the question was not that difficult. So please understand, for your future NEET PG and INICET exams, study the high yield topics, study them again and again, study them more deeper rather than going through the whole of orthopedics. Study the high yield topics again. Okay, so that is the gist of it. So let's go into the questions. The first question is an elderly lady who presents with low back pain. Bone scan, I've heard few of them telling me MRI was asked, but I think it was bone scan. Bone scan done reveals a Honda or an H sign or a pattern. What is the diagnosis? And they've also given an image like this where you can see an H-shaped structure being there. And where is that present? It is somewhere at the lumbosacral or at the sacrococcygeal junction that you can see it. The options are multiple myeloma, sacral insufficiency fracture, bone marrow syndrome, and acute osteomyelitis. So when bone scan is given, you're thinking of either acute osteomyelitis, you're thinking of maybe insufficiency fractures, multiple myeloma not very common, and also bone marrow syndromes can have. But H sign or a Honda sign is a straightforward clinching diagnosis. So it is a one-liner which suggests that it is a sacral insufficiency fracture. So this is something that has been discussed in theory as well, that an Honda sign or an H sign stands for sacral insufficiency fractures. Now what is this? Let's understand what a Honda H sign is and why do you get this sign. So in patients with osteoporosis, so anyone who has an osteoporotic bone, mainly the spine that gets involved, that bone becomes weak, and that bone is subjected to minimal trauma, can undergo a fracture. Now imagine a child or an elderly lady who has an osteoporosis. In elderly women, it's commonly calcium net balance goes down and you get osteoporosis. So in this patients whose bone is very weak, their spine is very weak, because they keep sitting or sleeping for a long hour, there is more pressure falling on the sacrum, and that can result in an insufficiency fracture of the sacrum. What does insufficiency fracture mean? That means that the bone is abnormal, the force acting on it is subminimal. It's not a severe force that is causing a fracture. It is a minimal force on an abnormal bone that is resulting in a fracture. So it's an insufficiency fracture because of osteoporosis. And in sacrum, whenever you have a fracture, it usually encompasses the sacral ala, and you'll have this line like this vertically. So it will usually form an H or a U-shaped fracture. Usually a H or sometimes a U-shaped fracture. And this H sign looks like the symbol of Honda cars, and that is why they call it as a Honda sign. So look at the clues in the question. You have an elderly lady, again a target population for osteoporosis, lady and elderly. Low back pain, there is no trauma mentioned, so we'll assume that patient has had no trauma. Low back pain, and you can see that there is an H sign that is present. So the diagnosis here is sacral insufficiency fracture. So we again going through it. It's a type of stress fracture, that is normal stress falling on an abnormal bone which is already weak. Where is sacral insufficiency fracture seen? Where is the H sign seen? See, basically it's seen in osteoporosis. It can be primary or secondary osteoporosis. Primary osteoporosis is the most common. Where do you see secondary osteoporosis? In rheumatoid arthritis, bone becomes extremely weak. There again you can have a Honda sign. Then other conditions are Paget's disease, osteomalacia, diabetes mellitus in patients who undergo radiation therapy. So all cases where the bone is osteoporotic. If you want to remember just two, remember osteoporosis and rheumatoid arthritis. Clinically, what are you looking for? Elderly female, complaints of low back pain, and no history mentioning trauma. Okay, if it was trauma, then the answer will completely change. So this is sacral insufficiency fractures. It's a concept from osteoporosis. Now, why did I say bone scan and not MRI? Because in MRI, you will not see a classical H sign. This H sign is seen whenever you give a technetium-99 isotope, and that is taken up at the area where there is a fracture. So you can see that there is an enhancement of technetium isotope at that region, giving a classical H pattern that resembles this Honda sign. It resembles this Honda car sign. That is why in bone scan is where you see your Honda sign, not in your CT or your MRI. In the MRI, you might see some edema at both sides, but you will not see a classical H sign. In CT, you will always see a break in the fracture. Can you see here how that break is visible? Okay, so this is how a sacral insufficiency fracture looks in a CT scan and an MRI. Please remember, it is seen in a bone scan and not in an MRI scan. Okay. Now coming to the second question. So this was a trauma-based question. A patient comes with a history of fall on an outstretched hand. He has pain and swelling along the anatomical snuff box. X-ray was done, which was inconclusive. There was no fracture seen in it. What is the next best step of management? Okay, so this is a protocol that you have to follow. There is a written protocol on patients who come with anatomical snuff box swelling and tenderness. When X-ray is not conclusive of anything, what should you do next? There is a written protocol. So your steps here, your options here are: one, will you do an MRI immediately to look for ligament injuries? Second, will you give him NSAIDs and discharge the patient? You tell him nothing is wrong, you can go without calling him back for review. Third is you'll put a thumb spica cast and you'll ask him to review after 2 weeks. And the fourth is, will you get an immediate CT scan done? Okay, so the treatment for this. So first you have to understand how will you clinically try to understand what type of fracture we are looking at, or what suspicion of fracture should we have. So when it involves the anatomical snuff box, and when there is a swelling, when there is bruising and pain in the snuff box, and patient falls on an outstretched hand, the thought process should directly go towards a scaphoid fracture. Whenever you hear that word anatomical snuff box, you're thinking of a suspected scaphoid fracture. Okay, this is something you have to remember for your clinics later as well. You're thinking of scaphoid fracture. So what are your keywords here? Fall on an outstretched hand, tenderness at the anatomical snuff box, and sometimes they might mention that scaphoid compression test is positive. Here it's not given, but these two things are enough for us to suspect scaphoid fracture. Now, how do you treat a patient with scaphoid fracture? So there is a protocol in place. So first you will get an X-ray. X-rays have to be specific for scaphoid fracture. You have to get a PA view, you have to get an oblique view, you have to get a lateral view, because these are the three views that will help you visualize scaphoid fracture. Because it's very easy to miss them. Small bone, very difficult to spot the fracture. So always get these three views. The best view is a scaphoid or an oblique view to look for scaphoid fracture. Now, when you immediately get it done, if you do not see any fracture, there is no fracture, the X-ray is inconclusive, then also there is a chance that you would have missed a scaphoid fracture, because in 25% of cases of scaphoid fracture, initial X-rays are normal. Now your question will be, sir, should we go ahead with getting an MRI done? Now think of this, if you are going to make a protocol, you're going to make a protocol in such a way that it is feasible for everyone. Anyone who comes in with a wrist injury, anyone who comes in with an anatomical snuff box injury, you cannot go ahead and get MRIs for every patient, because MRI is not a cheap scan. So when it comes to a protocol, we'll devise it in such a way that it is feasible for at least 80 to 90% of the population. So the protocol here is to not get an immediate MRI. It is to treat this patient whose X-rays were inconclusive as a scaphoid fracture, as a occult scaphoid fracture, and you have to do whatever you do for treating scaphoid fractures. That is, you will put a thumb spica slab. You won't put a cast immediately because there is a lot of swelling. You will put a thumb spica slab, which is going to keep the thumb in a position of immobilization. And then you will ask the patient to come 2 weeks later, and 2 weeks later you will again examine this patient removing the slab, and this gives you two advantages. One, you will be able to see another X-ray which now might be able to help you pick up a scaphoid fracture. Two, if any patient has had a small soft tissue injury which is giving him the pain and swelling, within that interval of 2 weeks, that pain, that swelling is going to subside. It is going to come down. So you will know that now this patient's pain is only because of a fracture, because any soft tissue injury, any sprain, mild ligament injuries get better within 2 weeks. Swelling also reduces within 2 weeks. So when you call the patient after 2 weeks, if the tenderness remains the same, if the pain feels like a fracture like pain, if the swelling also remains the same, then you know now that this might be a suspected scaphoid fracture, and it makes much more sense now to get an MRI done also if you feel the X-ray is still inconclusive. Okay, so this is how you treat scaphoid fractures. You do not get an MRI done immediately. You call the patient 2 weeks later. You treat an inconclusive X-ray as a scaphoid fracture, and after 2 weeks you have the luxury of removing the slab if you feel like everything has gotten better and this was just a soft tissue injury. Okay, so that is how you will treat scaphoid fractures. And later, if you still think there's an acute occult fracture, you can get an MRI done at that 2-week interval. But your judgment is better when you do this. If you ask every patient to get an MRI done, then that's not going to help you in any way. It's not going to help the patient also. So any patient with a suspected scaphoid fracture, this is the protocol that you follow. Okay. So the answer, again, coming back to what the answer was, you will put a thumb spica cast and you'll ask the patient to review after 14 days or 10 days, because then you will be able to judge the fracture better. Okay, so that was about the second question. Now coming to the third question, a 16-year-old boy comes with a progressively increasing swelling over the tibia with fever. Radiological examination reveals Codman's triangle and sun-best appearance. What is the best diagnosis? Your options are Ewing's sarcoma, osteosarcoma, giant cell tumor, and chondrosarcoma. Now I know most students are going to jump looking at Codman's triangle, sunburst appearance. They're going to put those two things in place and tell that, see, Codman's and sunburst is definitely seen in cases of osteosarcoma. So I'm going to tick osteosarcoma. Although your answer here is right, but I think the approach is not right, because periosteal reactions are not a clinching diagnosis towards telling this answer. Okay, Codman's triangle can sometimes also be there in Ewing's sarcoma. Sunburst appearance can sometimes also be there in Ewing's sarcoma. Okay, so it's not the right approach to deal with bone tumors. So whenever you're dealing with bone tumors, especially for INICET exams, approach it like this. This helps you in other ways also. See, what you have to look for is these features: age, bone, location, eccentricity, periosteal reaction, special reaction, and matrix. You look for these. Not that every patient will have these details given below, but look for these answers, and then you have a table for everything. You have a table for which tumors are seen in which age. You have a table for bone, which bones are more commonly associating which tumors, eccentricity, periosteal reaction, all of that. And I've covered all of that as to what tables these are. So you try to use this approach again there as well. So here we have two clues that have been given, three actually. They've given 16-year-old boy. So age is given, tibia is mentioned, and also Codman's triangle and sunburst, which are periosteal reactions. These are mentioned. So let's try to use them. First, let's see the age. Now we know that tumors are divided into ages. Most tumors are present at 0 to 20 years, but there is also which are common. In the first decade, it is Ewing's sarcoma, which is common. In the second decade, it is osteosarcoma, which is common. Then going into other tumors, 20 to 30 years, you have fibrous dysplasia. 20 to 40, you have giant cell tumor. 40 to 60, you have chondrosarcoma, and also you have secondary osteosarcoma because of Paget's disease and irradiation. At 60 years, you have all these METs, myeloma, chordoma, all of that. Now, based on just this table, we can now think of osteosarcoma being the best diagnosis. Also, Ewing's sarcoma can be there. First decade can go down to the second decade as well. But my first preference would be osteosarcoma. Now let me hold on to that diagnosis. Let me see another clue. The second clue is periosteal reaction. Like I told you, periosteal reaction are not directly proportional to the diagnosis, but they tell us what is the growth of the tumor. So if there is a solid periosteal reaction, that means that the tumor is benign, meaning the tumor is slowly growing, because of it the periosteum is slowly getting lifted, forming a benign or a solid lesion. If it is a lamellated, multiple layers of periosteal reaction is there, that is also called as the onion peel appearance, that means the tumor is somewhat aggressive, not very aggressive, somewhat aggressive. Okay. If it is spiculated, that is a sun ray appearance is seen, that again suggests that the tumor is aggressive. But if it is very aggressive, a very aggressive tumor will suddenly lift the periosteum up, resulting in formation of new bone there, forming a Codman's triangle. So a Codman's triangle there is given there. So a Codman's triangle is mentioned here. Codman's triangle and also 16-year-old boy. So when there is Codman's triangle given, I know that this is a very aggressive tumor. This is a very aggressive tumor. Now they've given you something to confuse you. So fever they've given. Fever is more commonly seen in Ewing sarcoma. But I know that this has a Codman's triangle. So this is a very aggressive tumor. This is seen in a 16-year-old, and that is why it is osteosarcoma. That is a more common diagnosis. So if you ever get confused between Ewing sarcoma and osteosarcoma, then this will help you. This approach will help you solve the answer. Okay. So although you've all gone with this approach of just finding out Codman's and then going to osteosarcoma, I'd suggest that the next time any question on bone tumors comes, please go through this approach of always looking at all the features and then coming to the diagnosis, because bone tumors can be extremely confusing if you don't do this. If you go systematically like this with all of these approaches taken in, then you will definitely reach the right diagnosis. Okay. Let's go into the next question. All right. So this is a question that's become an INICET favorite for everyone. They've been repeatedly asked in every consecutive exam, and still some students get this wrong. So that is something that is very shocking. So let's try to put a nail in the coffin and try to seriously understand the concept behind this question. There should be no more confusion on whenever they ask you about how to treat proximal femur fractures. Okay. 78-year-old presents to the emergency department with a right intertrochanteric fracture. What is the best step in management? Okay, a lot of students have seen 78 years and they've marked hemiarthroplasty or total hip replacement, whatever was given, just based on age. But you've not seen the next line that was given. That is, it is a right intertrochanteric fracture. Why is this important? Why is it important to differentiate right intertrochanteric and a right neck-of-femur fracture? Because they are different. Both of them are different. Look at these two fractures per se. So you know that a neck IT fracture is an extracapsular fracture. It is an extracapsular fracture, and a neck-of-femur fracture is an intracapsular fracture. Now why is this important? Because look at the vascularity. This is the vascularity of a proximal femur. If you get a fracture here, can you see how there are very less vessels in the distal fragment? So this distal fragment has a high chance in neck-of-femur fracture to go into avian. And what are the risk factors for this? If it is a late fracture, if the fracture is very late, or if the patient is old. In both of these patients, the vascularity of the proximal fragment might go off, resulting in avian of the area. So in these patients, the decision has to be whether to replace the head or whether to fix the head based on the vascularity of the proximal fragment. But if there is a fracture in the IT, there is good vascularity there. There is good vascularity at the intertrochanteric region, so very less chance of it going into avascular necrosis. There is almost no chance of it going into avascular necrosis, so there is no question of replacing the head. You should always salvage the proximal fragment here, and that is why you always fix. That is why in intertrochanteric fractures, you will always fix it because there is no chance of avian. Good vascularity is there. Okay, but in neck of femur, you have to make that decision, and for that decision, you have a table in place which we will discuss about. But this question is straightforward. The question here is talking about intertrochanteric fractures, which is an extracapsular fracture, which never goes into avian. So you will fix it, and as you know, in upper limb fractures, we usually go for plating. In lower limb fractures, you always go for nailing. So the answer here should have been either proximal femoral nail, which is called as PFN, or some students told me it was given as IM nailing. That is also a good enough answer. So nailing should have been the answer. So look at the X-ray here. This is a fracture, IT fracture, which was fixed with proximal femoral nail. There is no doubt in this. So DHS also is one of the options, but the best treatment for intertrochanteric fracture is to do a proximal femoral nailing. Then coming to neck of femur fractures. Now this is where it gets tricky. This is where you have to think about age. You have to think about when the fracture happened and all of that. Okay, whenever you get a patient with neck of femur fractures, ask two questions to the patient, or look at the options and look for two questions. One, what is the age of the patient? Second, what is the age of the fracture? Now, if the age of the fracture is less than 3 weeks, the treatment is different. If the age of the fracture is more than 3 weeks, the treatment is different. Okay, if the age is less than 3 weeks, so it is an acute fracture. So there is a good chance that vascularity might be intact. But again here, you should see whether the patient is old or not. So the cutoff here is 65 years. If the patient is less than 65 years, then you think of keeping the head. You think of keeping the head, and you can do an 3cc screw fixation. You can do fixation with cc screws. You can put 3 cc screws to fix this. Okay, that is how you'll fix it. In some cases, you can manage it conservatively as well, which we don't do much. Most of the time, we put a 3 cc screws. Okay, but if it is a fracture above 60, if it's a patient above 65 years, here his vascularity is already hampered. Although the fracture is acute, the patient's vascularity itself is hampered because of age. So here you have to think of replacing the head. Now when you replace the head, you look for acetabulum as well, because the hip joint is formed by the head and the acetabulum. If your acetabulum is intact, there is no arthritis of the acetabulum, you can keep that acetabulum and just replace the head. It is called as hemiarthroplasty, where you're only replacing one part of the joint. Hemiarthroplasty, half of the joint is being replaced. But if there is OA in the acetabulum as well, then you do a total hip replacement. So this is how you will treat a patient with fracture being less than 3 weeks. So you do an open reduction interfixation with 3 screws. Can you see here how 3 screws are put in a inverted triangular fashion? It is put in an inverted triangular fashion. This is done in patients less than 65 years where the vascularity is good. Okay, this is again an X-ray of that patient. Then in an elderly patient, you have two options. You can either do a total hip replacement or you can do hemiarthroplasty. Here you can see acetabulum is intact, so this is hemiarthroplasty. Here acetabulum is also replaced, so this is total hip replacement. Okay, this is an animation of the same thing. You can see how the whole thing is removed, hemiarthroplasty, and you're putting a prosthesis in place. Okay. Yeah, so that was hemiarthroplasty. Now let's look at the other subset of patients. In patients presenting to you with a fracture about 3 weeks. Here, if the patient is above 65 years, there is no point of doing anything. You have to go for either hemiarthroplasty or total hip replacement. No question of looking for vascularity, because more than 3 weeks, more than 65 years, high risk of AVN. But if the patient is less than 65 years, then you're thinking about, is the vascularity still intact or not? And how do you get to know that? You get an MRI done. If the MRI says that the head is viable, that means vascularity is still there. So you don't have to fix it. You don't have to give some vascularity to it. What you have to do is change the mechanics a little so that it heals better, because it's been more than 3 weeks now. You have to change the mechanics a little. You don't have to change the biology, just change the mechanics and the fracture will heal. And that you can do by doing an osteotomy. Two types are there. You have McMurray's osteotomy, you have Powell's osteotomy. Both of these make the fracture into going into a different alignment, which helps it heal. But if head is not viable, now what do you do when head is not viable? Then you have to give biological augments. To promote vascularity, and this can be done by either a procedure called as Bakshi's procedure, or it can be done with another procedure called as Mayer's procedure, or you can do a vascularized fibular graft. I'll show you images of all of this, but understand this based on viability of the MRI. Osteotomy if the head is viable, blood augments or biological augments if head is not viable. So look at this, biological augments can be Mayer's procedure, where you're removing a quadriceps femoris muscle pedicle graft and you're attaching it at the fracture site. So you're borrowing the blood supply from there. And other biological is Bakshi's procedure, where you're removing the tensor fascia lata muscle pedicle along with vascularity, again to promote the healing there. Other one is you remove a fibula along with its vascularity and you put it there. That is a vascularized fibula graft. This is done in patients where head is not viable. Okay, these are examples of that. You can see how quadriceps femoris is attached here to give vascularity. Here you can see how a fibular graft with its vascularity is removed and put in the neck of femur area. If head is viable, then you do osteotomy. Osteotomy is mainly done to either medialize it or to abduct the fracture fragment to promote healing. You're improving the mechanics, not the biology. So McMurray's medialization osteotomy and Powell's abduction osteotomy is the answer. So this is how you approach proximal femur fractures. First understand intra and extracapsular fractures, understand about vascularity, then you'll be able to answer it better. So here, the only word that should have mattered is intertrochanteric fracture. Doesn't matter if he's 78-year-old, 50-year-old, 20-year-old, 30-year-old, you will always preserve the head, you will always fix it. And in this, hemiarthroplasty is out of the question, or if with plating, screw fixation is out of the question. Boot and bar cast is sometimes done in patients who cannot be taken up for surgery, who have comorbidities. In this, comorbidities was never mentioned, so we'll never go into that. The best answer here is intramedullary nailing or proximal femoral nailing. Okay, so that is the answer. Now the fifth question, a little controversy around this question among students. WHO approved investigation of choice for diagnosis of TB spine is. Options are X-ray, CBNAT, CT scan, culture and sensitivity. So we all know that the first scan that we do whenever a TB spine patient comes is an X-ray. That is the first scan that we do. Not the best, but the first one. CT scan is only helpful if you're looking for bony destruction, not the best scan to do. MRI is more useful because that will tell us about how much collection, granulation is there, if there is any nerve involvement and things like that. Okay, but the best test whenever we talk about TB spine is to do a biopsy. Okay, it is to do a biopsy. But biopsy is not in the option. They're asking you what test will you send for after doing a biopsy. So once you do a biopsy, those samples, you will send them for histopath, you will send them for culture sensitivity, you will send them for something called as gene expert or also called as CBNAT or gene expert. Now out of these three, which is the best test? That has to be gene expert. So whenever you're looking for TB spine, whenever you're looking for tuberculosis of spine, in that infection, the best test after doing a biopsy is to look for gene expert. Culture sensitivity will not sometimes tell us about TB spine. It will not pick up tuberculosis, but gene expert and CBNAT is the best test here. So the answer here has to be CBNAT. If it was any other infection, pyogenic infections we're talking about, spondylodiscitis, which is not tubercular, then culture and sensitivity might have been the better answer. But because this is TB spine, the answer, WHO recommendation says that you have to do a gene expert or a CBNAT test to pick up that TB and then start the patient on ATT medications. Okay, so there should be no confusion here. Biopsy is the best test, yes. But after doing biopsy, what will you send for? And that is gene expert or CBNAT. Okay, so yeah, this is what I was talking about. So CBNAT is the best investigation. Now coming to the sixth question, this was based on ulnar nerve, again a very popular topic in INICET exam. So they're asking you what muscles are supplied by deep branch or which is not supplied out of the four, which is not supplied by the deep branch of ulnar nerve. So remember, this is not about ulnar nerve, this is about deep branch of ulnar nerve. Okay, so the options are third lumbrical, dorsal interosseous, flexor carpi ulnaris and opponens digiti minimi. So I've told you this many times that whenever we're talking about nerves, ulnar, radial and medial, something you have to by heart. You'll have to remember in detail which supply is there, and the best way to do that is to have a memory of images like this. Simplify the image into something like this. So ulnar nerve, if you break them down, you know that in the arm there is no motor supply, there is no sensory supply. Once it comes into the forearm, in the forearm it supplies 1.5 flexors, that is flexor carpi ulnaris and medial half of FDP. Then it comes to the hand, and when it comes to the hand, it travels under the Guyon's canal and it forms a deep branch. Here, after it passes under the Guyon's canal, it forms a deep branch, and this deep branch will then supply your adductor pollicis, which is the only thenar muscle, then all hypothenar muscles, all four interosseous, and third and fourth lumbricals. Please remember this. Third and fourth lumbricals, all four interosseous, all hypothenars and one thenar muscle, that is adductor pollicis, is supplied by the deep branch. The rest of them are supplied by ulnar nerve, not the deep branch of ulnar nerve. So if you go back to this question, third lumbricals, yes, that is supplied by the deep branch. Dorsal interosseous, yes, all interosseous are supplied by the deep branch. Flexor carpi ulnaris, no, the supply is given much higher in the forearm. So this is not the answer. Let's look at the fourth one as well. Opponens digiti minimi is again a hypothenar muscle. It is a hypothenar muscle which is supplied by the deep branch. So these three are not the answer. So by exclusion, flexor carpi ulnaris is the answer. It is not supplied by the deep branch. It is supplied by the primary branch of the ulnar nerve before it bifurcates into a deep branch after the Guyon's canal. Okay. Now coming to the seventh question. So the female patient who is a known case of rheumatoid arthritis, very important to pick this up, presents with complaints of neck pain and has features of cervical myelopathy. What is probably the cause of myelopathy? Few confusing terms here is one is what is cervical myelopathy. So break the word down. Radiculopathy and myelopathy are different things. Radiculopathy is when the nerve roots are getting affected. But if the cord is getting pinched at any point, we call that myelopathy, because of which patients will have weakness, difficulty in walking, gait disturbances, clumsiness of hand, things like that. So that is myelopathy. So whenever we discuss about myelopathy, it's in the cord level. It's a UMN lesion. Okay. Now they're telling you that a patient of rheumatoid arthritis has got some kind of UMN lesion. So the lesion is occurring where and because of what is the question. Is it atlantoaxial subluxation? Is it osteoporosis? Is it osteoarthritis? Is it cervical canal stenosis? Now few things we can rule out straight away is osteoporosis. So osteoporosis most of the times cannot give you an UMN lesion unless you have a fracture that is retropulsed back and hit on a cord. You don't get it, and not very common in rheumatoid arthritis. Osteoarthritis again cannot lead to myelopathy, so again that is ruled out. So you have two options here. One is cervical canal stenosis, which can give you cervical myelopathy. Second is atlantoaxial subluxation. How do you understand this? So to understand this, you'll have to know a little bit about rheumatoid arthritis. One table that I want all of you to understand in rheumatoid arthritis is which joints are involved, which joints are not commonly involved but are present, and which joints are never involved. This is going to help you solve a lot of questions of rheumatoid arthritis. So in this, a joint in spine that is commonly involved is an atlantoaxial joint. So whenever you have a patient of rheumatoid arthritis coming to you with neck pain, you always get a flexion extension view because you're looking for atlantoaxial C1 C2 subluxation or instability. So if I get an x-ray of that patient, it will look somewhat like this. Can you see here? This is C2. This is the anterior arch. This is the posterior arch of C1. This is C1. This is your C2. This is the dens of C2. This is the anterior arch. If you look at the flexion and extension view, can you see that there is a gap that is being formed between the C1 arch and dens? There is movement that is happening at C1, C2, and that is called as atlantoaxial instability, and this is more common because that area undergoes synovitis, it undergoes destruction, and because of which you will see C1 C2 subluxation. Now if that C1 C2 subluxation becomes very severe, it can pinch on the spinal cord. Can you see here how the cord is just coming out from the brainstem and that is getting pinched at the C1 C2 junction, and this can give cervical myelopathy features. This can give cervical myelopathy features. So this is how commonly in rheumatoid arthritis you develop atlantoaxial instability, which can go into cervical myelopathy. So whenever you look for rheumatoid arthritis, neck pain, always think of atlantoaxial subluxation. Does not always have to go for cervical myelopathy, but rheumatoid arthritis, neck pain, atlantoaxial instability. Okay, that is something you have to remember. Now coming to the last question, and this is a tricky question, and this one question I think is more of an INICET cadre of question. So a 10-year-old boy presents with pain and swelling in the right knee for the past 2 weeks, no history of trauma, localized tenderness over the distal femur, X-ray shows sclerotic changes in the metaphyseal region with sequestrum involucrum. Which of the following is the least expected causative organism? You have to read the question till the end. It's a long question. Some people might not read the whole thing and end up marking Staphylococcus aureus or Streptococcus thinking they're asking about most common organism in osteomyelitis. No, they're not asking that. They're asking you which is the least expected causative organism. So how do you decode this question? So whenever you have an INICET long question, search for keywords. When you search for keywords, you will think of 10-year-old, 2 weeks, involucrum, sequestrum, metaphyseal lesion. When you think of all of that, a 10-year-old boy having involucrum and sequestrum in the X-ray in the metaphyseal region, you know you're dealing with chronic osteomyelitis. Now, the question is, what are the organisms that do not cause or rarely cause osteomyelitis? We know about the few organisms that commonly cause. This is a table that we always study, that the most common organism, it is always Staph aureus. If it's an ulcer, open fracture, most common case, post-traumatic, post-surgery, it is Staph aureus. Other cases that we know of are exceptions like sickle cell, salmonella, human bite, Ignella, IV drug abusers, Pseudomonas, animal bite, Pasteurella, prolonged parental therapy, fungal organism. This is also something that we know about. But when it comes to occurrences, you'll have to exclude a few and then you'll reach the answer. So this is a table that I want you to remember. For future purposes, when you're thinking about most common organisms in osteomyelitis, there's a spectrum of this. The most common one we know is Staphylococcus aureus. Others are aerobic gram-negative bacilli like Enterobacter and E. coli and MRSA. Recently, there's an increasing trend in children to develop MRSA. So MRSA is also included in this. These are the commonest organisms. Then one step down. Other common organisms are coagulase negative streptococci, beta hemolytic streptococci, enterococci, anaerobic gram-negative bacilli like Clostridium and bacteroids. Other important organisms, doesn't mean least, other important organisms other than these many are Mycobacterium tuberculosis. Many of you have marked this thinking that Mycobacterium TB can never cause osteomyelitis. No, that's not the case. Mycobacterium TB also causes osteomyelitis and it is a common organism as well. So that's not the answer. Mycobacterium TB, fungal, Salmonella, Ignella, Pasteurella, Bartonella, and one more common thing in children is Kingella kingi. This is also common. So please remember this table, take a picture of this, note this down, because these are the organisms which are the usual suspects in osteomyelitis. Right from the top going down, that will show you from the most common to not least common but are commonly seen. Okay. So now if you exclude based on this table, based on the table here, Streptococcus pyogenes is pretty common. So that's not the answer. Escherichia coli, yes, that is also pretty common. Mycobacterium TB is also pretty common. Klebsiella pneumonia is not a common organism causing osteomyelitis, and that is the answer. So the answer based on this table, very important table, is Klebsiella pneumonia. So this is how you should have been able to decode the answer. Yes, there would have been a little doubt between Mycobacterium TB and Klebsiella pneumonia. Hopefully most of you marked it as Klebsiella pneumonia. So that was about questions asked in INICT from the orthopedic point of view. Please tell me in the comment section if there is something that I've gotten wrong or something that I've missed or any question more that needs to be included. 8 is a good number of questions that's come up in orthopedics, so you can expect more to come in NEET PG. Now, what do you do with this information that I've given you? So for the people who think they've done well, congratulations, you passed a good hurdle. But for the people who think they've not done well, which I think is 80% of the people who still think that they've not done well, for them, I still like to congratulate you because you've written a very important exam, and this exam can serve as the best mock-up exam for your upcoming most important NEET PG exam. So take this as a mock-up exam. Take all the negatives and try to improve on them. Take all the positives and carry them forward for your NEET PG exam. And I hope all of you do well. If you want to get in touch with me, I've put my Instagram and my WhatsApp handle here. Please remember that this is just a mock-up. You will do much better in the NEET PG exam. Use all the concepts that I've given you here and practice that in your NEET PG exam. All the best. Happy learning.